Thanks, Megha, for a very generous introduction. Um, Today's topic, uh, what we are going to speak about, is on malignant spinal cord compression. It's one of the very common scenario that what we see in a cancer setting, and the discussion will be limited to epidural spinal cord compression. I'm not going to take it into the dural and the central canal origin. It's seen in up to 5% of the patients with cancer. And in one-fifth of the patients with cancer, it could be an initial presentation. And cord compression per se could present with a lot of morbidity, and it could lead on to an early mortality, and which could erode significantly the quality of life of the individual suffering. So it's a multimodal approach, and we require surgeons, radiation oncologists, and supportive care physicians for this. So we have an excellent panel for this. We have Dr. Sushma Bhatnagar, professor and head of oncoanesthesia, pain and palliative medicine from All India Institute, Dr. Akshay Tiwari, musculoskeletal surgeon, and an oncologist from Max Hospital, Saket, Delhi. We have the privilege of having Dr. V. Srinivasan, a radiation oncologist from Mayot International Hospital, Chennai, and Dr. Ritesh Sharma, another radiation oncologist from Batra Hospital, New Delhi. So, without wasting any time, I would go on to the panel questions, and I would like to go on to our surgeon first, and I would like to ask him on how do you or we assess for spine stability in a patient with malignant spinal cord compression, and how do you generally decide the role of spine stabilization procedures in these patients?
Yeah, thanks, Naveen. And I think that's a very pertinent question. Not just because, as you said, spinal involvement is so common in patients with cancer. Also because most of these treatments have to be individualized to the patient. Not all patients with the same kind of spine involvement will be treated the same way. And when you talk of evaluating for stability, the first thing comes to mind is the longevity. And then, of course, you want to look at how unstable the spine is and what is the extent of intervention that you would want to offer to the patient so that the benefit versus the procedure it goes in favor of the patient. A patient who has got multiple visceral mets, who's got brain metastasis, the outcome after discussion with the primary physician is not good. Probably you would accept some kind of instability and focus more on other quality of life interventions. But a patient where a longevity is good, the extent of disease is such that the patient is expected to survive for some years, you would want to go aggressive. And that is where scoring systems like the Tomita or the Tokuhashi systems, even modified Bohr system, where you look at the extent of visceral involvement, the extent of bony involvement. And then, of course, you have the final instability neoplastic score, which comes in very handy. It's kind of a Mirrell score for the spine where you can objectively discuss. So when I have my radiation oncologist arguing or discussing with me whether to offer surgery or not, this is where the spinal instability neoplastic score comes in handy, where we can have an objective evaluation, see whether the patient's spine is unstable or not, and if yes, what is going to be the best mode forward.
Thank you, Dr. Tiwari. You just spoke about the spine instability neoplastic scoring. Can you tell us how its impact in your day-to-day decision making in a patient with a cord compression?
Yeah, so as I said, it's an objective score which takes into account the presence or absence of pain, the extent of collapse, the involvement of the posterolateral spinal elements, then the type of lesion, whether it's lytic, blastic, or mixed, the location of the spine, whether it's the junctional spine or a semi-rigid part of the spine, and all this merges into the score, uh, which gives you an objective way of saying that yes, this patient has an unstable spine and something must be done.
Yeah.
And it comes in very handy, yes. And then you can have the same score which can be applied by the radiation oncologist, by the radiologist, by the surgeon, and the communication about the extent of instability is the same across board. So yeah.
Yeah, thank you, Dr. Tiwari. Another question for you. Can you discuss some of the outcomes of surgical interventions in patients with malignant spinal cord compression? Like when you choose an open surgery versus an vertebroplasty or a kyphoplasty?
Yeah, so generally our emphasis is on the least intervention. The least morbid intervention is always welcome. And
Mhm.
wherever we can get away with a vertebroplasty or a kyphoplasty, we prefer that. Having said that, again, there are recommendations where, suppose there is a solitary spinal met, you would also want disease clearance, and that is where you would want to go for corpectomy and global fixation. Where there is intermediate prognosis, where you are looking at short to mid-term disease control, you may want to just go for posterior stabilization and depend on radiation for the anterior disease. And in patients where you think you have an adjuvant treatment which is going to be very effective, for example, for myeloma or tumors which are radiosensitive, you may want to go for a minimally invasive thing like the vertebroplasty or kyphoplasty. Generally, patients with myeloma or patients where you have good adjuvant available in the form of radiation or even chemo, you prefer a minimally invasive method like vertebro or kyphoplasty.
Thanks, Dr. Tiwari. It was very useful. My next question is to Dr. Srinivasan. uh, about the role of MRI spine, especially with regards to imaging protocol and timing in a patient with cord compression.
Yeah, so MRI spine is going to be the standard now because that will going to give you a lot of information, including the soft tissue information. So normally we do T1, T2 weighted imaging, and now with the help of diffusion weighted imaging, we are able to clearly find out the amount of spinal cord involvement and the bone involvement also, and the disc also is very clear in if you do an MRI spine, and that should be the standard before you decide whether this patient will require radiation or the patient can has to go for surgery as early as possible. So it will help you to understand the stability of spine before you decide what is the right treatment of choice.
Right. And is there an MRI based grading that you normally use in your practice?
Yes, I share your slide also, like what the surgeon said. So we look at two important things. One is the spinal instability neoplastic score, which is called SIN scoring, and any SIN scoring between 0 to 6 we consider radiation. If it is more than 7, then if the surgeon comes into the picture, and we decide whether to go for a stabilization. And another important thing is the Bilski grading. Bilski grading is graded from 0 to 2. The 0 and 1. One is just, I shared a picture where you can see that you can search for Bilski grading, and where grade 0, the spinal cord is not at all involved, only the spine is involved. Grade 1 is 1A, B, and C, where there is just abutment of the spinal cord and the spinal cord is not involved. So grade 0 and 1 are the ideal situation where you go with radiation upfront, and if it is grade 2 or grade 3, then you have to go for surgery upfront.
Right. And will your approach be different in a radio-sensitive versus radio-resistant tumor with regards to radiation?
Yeah, seriously, I think now Dr. Ritesh will talk about SBRT. So when you think about giving conventional radiation doses or very high ablative radiation doses, you would decide on the sensitivity. For lymphomas or myelomas where you see spinal involvement, you don't need to go for the high ablative dose we call SBRT of the spine. we can just give conventional dose, and once the spine is stabilized, and you can just reduce the dosage, and because they are very sensitive, you can just give it over 5 days or even maximum 10 days, so that the tumor literally disappears or it literally melts. We call these are the tumors where you can see the disease melting with radiation.
Right. Thank you, Dr. Srinivasan. My next question is to Dr. Ritesh Sharma, uh, taking on from what Dr. Srinivasan spoke about the role of conventional RT versus SBRT in a cord compression.
So there are few factors which which help in my decision making. One is the cost. One is the availability of the software and the hardware. Then the tumor, which is close to 3 mm from the cord, most of the trials and the studies do not take. And then the time which is involved in the SBRT, because SBRT requires an MRI planning and contouring, which is a labor intensive process. I think Dr. Srinivasan would agree to that. So if I have a patient who has cost issues and there is very recent power loss.
So Naveen, we have last 2 minutes. I'm sorry to interrupt. I feel very bad.
Okay, I'll be quick. So factors. So I think SBRT generally gives a very good response in terms of pain relief, and conventionally people say it is 60%, but in our studies I have seen in my previous institute up to 90% pain relief and local cure at 1 year has been seen. So, but there are factors. The MRI has to be done. If the logistics do not apply, then I would rather first and foremost give him conventional fractionation, which can vary from 8 gray single fraction, 20:5 or 13:10. In myeloma, you don't need to increase from 13:10, but in other cases, if you feel that there is a little bit of epidural compression still left, by the end of that, you can give some SBRT boost.
Yeah. The one more question for you, sir, about how do you prognosticate outcomes of radiotherapy in a patient with cord compression? Maybe I would request you to keep it short, maybe 30 seconds, so that I'll go to next panelist.
Yes, so prognostication would require a combination of SIN score, combination of Takahashi score, and the visceral disease and everything. But we have to tell the patient that once we give SBRT, the chances of pain relief is more than 60 to 80%, depending on the type of radiation what we are giving. And we have to, even the chances of power recovery are there, which we have seen. So, of course, the systemic disease has to be taken into consideration. But locally, yes, once we give radiation in form of SBRT, the local response rates are very good. So locally, of course, I would like to be in a good prognostication for the patient, but that will not exclude the other systemic factors.
Yeah. Sushma madam, what are the different types of pain that you commonly see with cord compression, and what would be the approach to manage that pain?
Naveen, there is no time to speak. You summarize this.
Mhm.
Vega has said 2 minutes. The 1 minute is over.
Yeah,
So,
I think I will
you
still want
summarize.
to hear from you, madam.
So the pain, I think pain, with the biggest pain patient will come with the why this is, what type of this thing is happening. Something is happening in my lung, something is happening in my breast in cases of breast cancer, in prostate cancer cases, prostate cancer patient. What is why I am unable to walk? Why I'm bedridden? Why my pain my legs are weak? So biggest pain is this. So for one is so we have to explain to the patient that why this is happening to the patient, and then patient will have to accept this, that this is the reason I am having the pain. And most of the time, if we go to the definitely, if you want to listen to the type of pain, it will be most of the time it is bony pain, which will be dull aching, but it will be severe in nature sometimes. When it is associated with fracture or sometimes displaced vertebra, definitely it will be severe in nature. But most of the time, what we see that patient is having very agonizing with that. Why my legs are weak? So we have to explain to them that why your legs are weak and what we can do the best for them. So they want to hear from us the uh, uh, about the disease, and then the realistic hope what is possible. So this is
Generally, what kind of prescription would be it will have for this pain? What all the
first of all stabilization. First of all, whatever is happening is stabilization, and then the integrated approach, whether radiotherapy can help or surgery can help. If surgery can help immediately, performance scale is better, and it is single vertebra, definitely surgeons can help a lot. If radiation oncologist, definitely simultaneously the consultation should go, and then it's high dose steroids plus NSAIDs will work if it is mainly a bony pain, or paracetamol, simple paracetamol. And if pain is not relieved, then definitely we will like to use opioids in a titration and with the very excellently supervised manner. It's not should not be any time, but definitely we should try first paracetamol and NSAIDs, and then simultaneously the all consultation should go. So paracetamol, steroids, NSAIDs, and the consultation should go for radiation oncology surgeon. And then if pain is still not relieved and you consider that is a malignant pain, then is opioids will be the drug of choice.
Yeah, I can see, Megha, you're becoming restless. We will
Sorry.
summarize this
This is
panel. It
such
was
a
a crash
wonderful
course.
discussion ongoing, and I really didn't want this to
Yeah.
end.
Yeah,
But
we will end the discussion here.